Welcome to Chronic Pain, Managing Without Opioids. We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. We thank our program partners, Pain BC, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all these items when they're available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. David Taubin. Dr. Taubin is a clinical professor in the Department of Medicine and Anesthesia and Pain Medicine, board-certified in internal medicine and pain medicine, directs UW Medical Student Pain Education, and is founder of the UW Telepain, a video conferencing providing education and support to UW Northwest regional primary care providers. He's also a principal investigator for the UW's NIH Center of Excellence for Pain Education. Dr. Taubin studied philosophy at Yale University, medicine at Tufts University, and has a medical residency at the University of Washington. And now I'll hand it over to Dr. Taubin.
Thank you, Angie, and I appreciate those joining today, and certainly the Work Wellness and Disability Prevention Institute for inviting me. My topic is, as mentioned, chronic pain, managing without opioids. And I have no financial conflicts of interest. I have a number of grants that are helping support the work we're doing here at the University of Washington. The objectives are to discuss the fact that chronic pain, pharmacological treatment with medications, should not be opioid monotherapy. We'll talk about the role and value of non-drug options for managing chronic pain. We'll be discussing the clinical value and side effects of so-called adjuvant drugs in the management of pain. And we'll understand, hopefully, by the end of this, why, when, and how alternatives to opioids will improve outcomes of your pain management plan. So this is a 21st century view of opioids in chronic pain. Starting with the 2017 Canadian guidelines recently out. And it starts with the very topic we're discussing right now. When considering therapy for patients with chronic pain, we recommend optimization of non-opioid pharmacology and non-pharmacological therapy. The Centers for Disease Control of the United States in 2016 released a recommendation number 1, just like the Canadian recommendations, starting with non-pharmacological therapy and non-opioid pharmacological therapy are preferred. And in Washington State, where I've been involved in guideline work since the mid-2000s, table number 1, cognitive behavioral and non-pharmacological therapies listed there. And we'll be going through many of these in the course of the webinar today. The point being, in the 21st century, chronic pain is all about not using opioids, or so we thought. Let's go back a couple centuries to Descartes. This is the famous boy burning his foot. That's nociception, and a bell went off in his head. Nociception means input from the periphery to the central nervous system of some kind of danger that damages a foot, pun intended. And currently, pardon my poor Latin, but it hurts, therefore opium. That seems to be the tradition at this point. However, in the early 21st century, just some years back, Karen Davis from Toronto visited us and was able to communicate a lot of interesting information about the attention-paying aspects in our brain, which increases salience. In other words, it's important. The little boy burning his foot, it was important that he know that his foot was soon to be afire. Or mind wandering is the state of mindfulness, or the default mode network when we look at this in functional MRI. And all of these are directly connected to our anti-nociceptive system. This is the internal pain blocking mechanisms which suppress the signaling. which will reduce the intrinsic attention to pain if it's not terribly important. I make a big point of this because this is a very critical role in a lot of the non-pharmacological strategies, as well as the pharmacological strategies in terms of where they locate. An important concept is that pain is not nociception. The little boy with a burnt foot, certainly it feels that way for him, and that's the experience that this individual is having. But the context, the cognitive set, the mood, and the chemical structures of the individual based on disease state, and even genetics will have some role on what that pain experience is like. In fact, as we've seen back in the 15th century, that one can have nociception without pain. When I show this to our students, I say, what's wrong with this picture? It takes a couple moments. I think you're all finding out right now that that weapon in the gentleman on the brown horse is actually his severed leg. And he is certainly not feeling pain at that point because, as Bill Fordyce at the University of Washington decades ago said, people with something more important to do hurt less. And that's the descending inhibitory pathways indicating to this gentleman that it's far more important to survive this battle than to fuss about the broken leg, at least at this time. This has been well described also in the 20th century. Henry Beecher, who was a anesthesiologist at battlefields and Anzio Beach in Italy in 1942. It was a horrible contest of weaponry and damage, and he noted that though not a majority, but quite a number of the soldiers who had catastrophic injuries reported no pain at all, requested no opioids, i.e. no morphine at the time, some of them for as long as 72 hours later. Another example of how the brain will determine what the pain experience represents. Now, we also see in our clinical practices, at least many of you certainly have, phantom pain. And this is an example of pain without nociception. So it goes both ways. Ramachandran, back in the Phantoms of the Mind, had a wonderful book, by the way. He identified the phenomenon of phantom limb, and it maps quite nicely to the homunculus. Again, identifying the experience of phantom limb takes place not in that absent extremity. Introduced mirror therapy, which is telling the brain that that hand is actually there, basically an illusion that will reduce pain intensity flares. It doesn't magically remove phantom limb pain, but many a patient will report the experience of pain is less intense. And some work done by Lorimer Moseley, who's a neuroscientist originally trained in physical therapy, has introduced graded motor imagery, another strategy, non-opioid and non-drug strategy, where the individual determines left and right-handed appearances and will improve accuracy and speed as training proceeds. Some work at the University of Washington done by some of our colleagues listed there have introduced virtual reality in the burn unit. It is said to be the oldest video game ever made. I'm not sure that's quite true. You can see how primitive the imagery is. But most interesting in the bottom left, you can see that with the introduction of virtual reality, the temperatures of the brain, the fire that's represented in these images, is reduced by being someplace else in a mind-wandering state, in a place other than that pain experience. This is now being called a dynamic pain connectome, again, thanks to Karen Davis and her team. And we can see some work done actually 10 years earlier than today, that if an individual is thinking that the pain is going to be bad, it will be bad. We call this currently pain catastrophizing, but the imaging on the brain on a functional basis can demonstrate that preparing the brain to have a bad experience with stimulation, anticipated, perhaps as being worse than it is, will increase the signaling. So pain is indeed in the brain. If we take a quick look then at more relevant to our clinical patients, the adverse childhood events discussed by Bob And and his group quite some time ago. You can see significant events. You can read through them. Unfortunately, the world is full of this awfulness, and many of our patients who present to our pain clinic describe this, certainly many of your primary care practice patients as well. And you can see in the right bar diagram that the more points one gets, adding 1 point each for the significant events on the left, mean outcome of comorbidities, the number of bad things on the right, will also be increased. So there's no doubt that we see this in adverse childhood events represented to subsequent behaviors, but we also see it in chronic pain. For instance, and sorry for the busy slide, this is a manuscript that our group has just submitted and has been accepted by the Journal of Pain. We identified using a 4-question PTSD screener. The fewer the questions you answer, or conversely, the more you answer on the top bar, the higher the correlation with all the domains of pain intensity, interference with activity, quality of life, oswestry, mood scores, PROMIS global quality of life, as well as the opiate risk and alcohol audit C-score. All increase as pre-traumatic events accumulate in our patients' lives. So if we look not backwards to what's happened to our patient before, but forward, the burden of chronic pain, thanks to Dennis Turk, who's been working in this field for quite a while. You can see in terms of functional activities, it takes a big impact on simple things like activity of daily living, household chores, leisure activities, and fatigue. Social consequences, marital relations, intimacy, social isolation. We know, in fact, that social isolation alone will increase the sensitivity of the brain to pain stimuli. Healthcare costs, disability, lost productivity, some of the socioeconomic consequences, and certainly emotional functioning, irritability, anger, why me, and why can't they find this answer to this problem, anxiety and depression, all key components. So when we're making a determination about what to do, now having a bit of an understanding of how complicated pain is and how it cannot be separated, the biomedical from the social and psychological, as well as environmental factors that our patients live in and have lived in previous to their presentation in your office and will go back to once they leave. Let's go forward. Let's look at the goals of our treatment. Well, acute pain is very different than chronic pain and palliative care pain management. Acute pain, we expect recovery. By definition, it's acute. It will resolve. It's a symptom, and we just facilitate the recovery process. Opioids are appropriate in this circumstance to facilitate recovery. Chronic pain is a disorder. It's a complicated disorder that I just outlined, and we do not expect the pain to resolve because it's by definition chronic at that point. And the illness or injury has often resolved. Many cases of chronic pain, in fact, most, there's nothing more that nature has to do in terms of healing, yet the pain persists. And on the other end of life, palliative care, we're focusing on comfort. And opioids, again, are clearly indicated. If we look at the different pain diagnostic types, I've already alluded to nociceptive pain. And this is important because this helps us select which type of treatment, and we'll get into this later in the webinar today. That nociceptive pain is pain that's driven from actual or even threatened, as we saw from the imaging. The anticipation of pain will stimulate signaling that is experienced as nociceptive. It's due to the activation of those little free nerve endings, delta and C fibers, that introduce the sensation into the human body. Neuropathic pain is pain caused by a lesion of the somatosensory nervous system. In central pain, it's initiated by a primary central nervous system disease, like such as post-stroke or multiple sclerosis or Parkinson's disease, and a whole host of others. The new confusing term for some, largely because you may not have heard it yet, it's just since 2017 that the International Association of the Study of Pain has published this nociplastic pain. I think this best links to what has been called central sensitization, such that pain arises from something awry related to nociception without evidence of actual or threatened damage that causes the activation of these nociceptors without evidence of damage in the somatosensory system. Again, a puzzling condition, but we see as centralized pain syndromes. And I've highlighted, this is wonderful work done by Mohammed Yunus, began along this line as a rheumatologist back in the mid-1990s. A more recent publication, but 10 years ago, still applies. And you can see, as a rheumatologist, on the top is fibromyalgia. Just to its left, not experienced as somatic pain, but yet is PTSD, and then chronic fatigue syndrome just to the right of it. But look at the host of other common primary care conditions that represent centralized pain: irritable bowel tension, headache, migraine, temporomandibular disease, myofascial pain syndromes, chronic pelvic pain syndromes in both men and women, and painful bladder syndromes, otherwise known often as interstitial cystitis. These are all centralized pain syndromes, and if we hearken back, and I'll quote the British psychiatrist Henry Maudsley, "The sorrow which has no vent in tears may make other organs weep." So this is a physician noticing, and his focus, of course, was in psychosomatic disease. But this is not a psychosomatic condition because the brain activates. We see it as real pain, and the intensity of the reported pain by these individuals correlates with the degree of functional MRI activity. So all this is real pain. This is experienced as pain, and our challenge is to pick the right kind of condition. So if your patient tells you pain is 12/10, what might that mean? We can see from the Department of Defense and VA visual analog scale, the verbal anchor is pain is as bad as it could be, which we're accustomed to, but they add nothing else matters. I think that's a key point, and we'll harken back to that in a bit. But if nothing else matters, pain salience is on, and seeking pain relief becomes the number one focus of our patient. And when nothing else matters, the phenomenon then becomes horror in the patient. And in our patients, and I've used this line regularly, and I refer to this as an organ, the brain. When your brain is on fire, I can't help your pain, and be able then to move the conversation to looking at other strategies. So let's get beyond the 10-point pain scale. Currently recommended are a host of measures, and I'm going to review, having talked a little bit about understanding pain, a little bit about assessing it, and then we'll get into the specific treatments. The CDC, the Washington State Agency Medical Directors Group guidelines, we're working considerably with the Oregon State, and many others are including a number of measures beyond the pain intensity. You can see them listed here. The first three are patient-reported outcomes, where the individual reports what their experience is, and then adherence monitoring, which we certainly need to be focusing on if we're using opioids. This is the PEG tool. I would recommend it to every one of our listeners who sees patients and is trying to make that assessment, because yes, it does ask how much it hurts. Pain as bad as you can imagine. This is a screenshot from the Washington State guidelines where we initially published that, but also pain interference with enjoyment of life and pain interference with general activity. This is great work done by Aaron Krebs, published back in 2008, Journal of General Internal Medicine. These three questions will get you into the domains beyond just the experience of nociception, but the social and psychological impact of pain on our patients. One of the other components, I'll go back a second, you can see sleep interference number 3 on that slide. If an individual doesn't sleep, their pain is worse. This is a now somewhat older article, but when it first came out, I was pleased to see this is a validation of the fact that when our patients don't sleep well, their pain is worse, and you can see there's nearly a 50% worsening of all of these domains. This is acute pain. This doesn't represent chronic pain. That work hasn't been done, but I think we can take a at least metaphorical leap forward and assume that when our patients don't sleep well, and therefore we need to attend to it, their pain is worse. Let's get more into the mood domain, and we're going to fly through this so we can get into the general topics and be able to answer questions in a bit. But here's the PHQ-9 in the background. It's an excellent screening tool. 0 is not at all. Nearly every day is 3 points. And you can see down the list are the domains of concern that the DSM-5 has identified. They generally map nicely, the PHQ-9 and the DSM, actually 4 when it was first published as such. The GAD-7 is an anxiety tool. Our experience at the University of Washington has been though 60% of patients presenting at our pain center do have depression, nearly 50% also have significant anxiety. And just asking the 2 questions on the PHQ-9, the top 2 or the PHQ-2, or not asking any at all of the GAD-7, one can frequently miss significant anxiety. We miss it if we're not prescribing benzodiazepines, but why is it that so many of our patients are being prescribed benzodiazepines as well? Must be that they're anxious, and there's no indication for chronic benzodiazepine, even in the psychiatric literature, for managing anxiety long-term. So a PHQ-4, I'm going to be very careful about the number of questions we ask our patients to fill out. So we had the PEG, 3 questions, the PHQ-4. You can see there's 2 questions off the top from the GAD and 2 questions off the top from the PHQ-9 as indicators to us that if the brain's on fire, we will not be able to improve the individual's pain unless we address that. Here are the 4-question PTSD screener that we recommend. Work recently published by Marasco et al. In Journal of Pain actually just a few months back, identified that patients who report pain and on longer than 90 days of opioids, fully 15% of PTSD and over 50% have experienced child abuse and neglect. And I'm not sure treatment of PTSD, child abuse, and childhood neglect is evidence-based support for the use of opioids. And that's been one of the biggest problems that we've been encountered in the opioid epidemic in Washington State. We also know, and again, you can see on the left text, 50% moderately severe, anxiety 25% moderately severe, childhood abuse, neglect more than 50%. This represents the highest risk patients who have co-occurring psychiatric and addiction disorders present on the highest dose opioids. Again, a clear error in our ability to properly understand pain and therefore to properly treat it. So there's an app for that. This is a PTSD app developed by the U.S. Department of Defense and the Veterans Administration system. This is open to public domain. One can just recommend this to their patient as easily as they could to the Recognize Hand app that Laura Mosley did so nicely and is available on a phone, just like the PTSD. Unless you have a trauma-based therapist in easy reach of your clinical site, or an expert in PTSD management, one needs to address this, and this is perhaps a first step in going that direction. We at the University of Washington have developed, and I'm just showing this an example of how important I have found this, a tracking tool. We've named it Pain Tracker, and you can see in the middle of the slide the items in red, the opiate risk score, the PTSD score, the sleep apnea score, and a fibromyalgia score, which I'll speak about in just a moment, to be able to broaden our not only biomedical thoughts about the indications for some of the treatments we might use, whether it's focal pain or widespread pain. The individual involved, we can identify at the time of the visit and whether our treatments are actually making a difference. Dan Claw and others have identified the importance of widespread pain. Again, a screening tool that one can pick up right off the internet. Just look up Claw, fibromyalgia, and JAMA just a few years back. And I printed out a stack and we've embedded it in our tool, but when the patient doesn't fill that out in advance, I will administer to this patient so I can understand whether or not the treatments should be directed to a focal area or to a widespread pain complaint. Importantly also, these components, for those of us who are evaluating patients who have knee or hip arthritis and are recommending them to have an orthopedic procedure to manage that, very appropriate. But the higher the degree of fibromyalgia, the higher the likelihood that the patient will continue to report pain and will have a higher dose of opioids associated with their management immediately post-operative. So the way the brain is responding to these signals can be predicted and should allow us to have a better view of what's happening. This is work done by Dan Claw and his group. Dr. Williams as well, current president of the American Pain Society, has also been the psychologist managing this. This is another app. Just past week when I was seeing a number of patients, some new, some follow-ups, I recommended that they go to this. It's a free app. You can see the different domains, understanding the disease, managing sleep, learning how to relax, pace, thinking differently. Many of the things that we're talking about right now introduce patients to the broader concept that perhaps opiates may not be the best idea. This is another tool. This is a paper version, and you could just download that today. And depending on what time zone you're in, you can even introduce this afternoon. You can see we get a widespread pain map, not a body map, but just a listing, pain intensity, enjoyment of life, general activity. You have the PEG, we have the PHQ-4. Again, a quick tool, and I've timed patients. I've handed them this form, and it takes under a minute, usually the time it takes me bungling to get logged on to my electronic health record. But in that short amount of time, you'll be able to make real progress in understanding the other domains of pain. So I know this is not about opioids, but one needs to know when they are indicated because we don't want to run away from one of the most effective treatments for acute pain when it's moderately severe and severe. Perioperative pain, which is a big nociceptive blast to the individual. It could be worse if they're anticipating, hence patient education before they go in for surgery, indicating that they will hurt. It will get better, as we would expect, and we could reduce the pain salience as they're recovering. Cancer-related pain syndromes, often many of the treatments prove refractory to the other non-opioid pharmacologics, and end-of-life palliative pain when high degree of function is less important than high degree of comfort to allow a quality of life at that stage. Unclear and uncertain is the role of opiates for chronic pain. And Roger Chow and others at the University of Oregon Health Science University, and his group published in Annals of Internal Medicine a few years back and supported by all the current guidelines, is that we just don't see any study of opioids long-term improving pain function or quality of life. And if we're not measuring function or quality of life in chronic pain, my thesis here is that we are never going to be able to figure out the correct treatment. Opioids can be a problem post-surgery as well. We know that almost 20% of patients who did not use opioids before surgery were using opioids long-term, 10% as long as a year later, and that there's a 44% increase in the likelihood they become long-term opiate users compared to patients not receiving that prescription. So therefore, initiation may lead to their longer-term use. And work done by some members of our group, Mark Sullivan, especially the senior author, identified in the Midwest in the United States that more than half the patients who are on opioids longer than 90 days were on opioids for the duration of the survey, several years, that was conducted using electronic database on their prescription behaviors. Tapering patients is a challenge. I won't go into it, but if we're going to talk about non-opioids, we've got to talk about reducing opioids because opioids will interfere, just like they do with chronic headache, will interfere with our other treatments. Again, not well studied, but certainly those in clinical practice will recognize that drugs work better if we're not adding a promoter to this. So the meat of the topic now is, if not opioids, what then? Patient education, very important. I showed you a couple of apps. I think setting expectations is critical. It will reduce the salience and improve the individual's willingness and motivation to pursue other things that seem a lot harder than just taking a simple pill. Multimodal analgesia does include non-drugs. Exercise of any kind will reduce pain intensity. Wiggling a finger will help that bad knee. It provides input into the motor and sensory cortices. The brain doesn't like a vacuum, just like that absent hand produces pain, just like the immobilization of the ankle might produce complex regional pain syndrome. Movement anywhere will improve experience of pain. Nice work being done by our physical therapy colleagues that can support that. Sleep hygiene, since nearly all our patients don't sleep well, and many of the drugs we use to promote sleep are not terribly good. Some are, I'll get to that in a moment, but sleep hygiene, that is something that can be coached and counseled by any clinician, or one can train others in their clinical practice to offer techniques for sleep hygiene. Again, there's a whole host of apps for that. Cognitive behavioral therapy, mindfulness-based stress reduction, powerful evidence base that support prolonged improvement in pain intensity. Work by Churkin and Turner, recently published in Journal of the American Medical Association, identified 50% reduction in back pain in both cognitive behavioral therapy and MBSR groups. And at 1 year out, the MBSR was actually sustaining that 50% reduction. The CBT was dipping a bit. It wasn't statistically significant, but it tells us that CBT requires a therapist to get moving, but MBSR is something people can take away with them for the rest of their lives and have a treatment that works exceedingly well. Acupuncture data, manipulation therapies, again, are effective. The power of the effect is difficult to demonstrate because of the quality of the studies at this point, but these are multimodal, non-drug strategies. And if we're going to get into the non-opioid drug strategies, acetaminophen, anti-inflammatories, tricyclic antidepressants, serotonin norepinephrine reuptake inhibitors, and anticonvulsant drugs. And we'll spend a few moments on that just upcoming. So my best effort here, and I apologize, this is just comparing effectiveness. This is not a meta-analysis. This has been a big challenge to sort out how much effect we will see with exposure of our patients to a variety of treatments. Let's do the easier ones on the left, because there's been some relatively good work done on the antidepressant groups. Again, opioids, no long-term qualitative evidence. Tricyclic antidepressant drugs and the serotonin norepinephrine reuptake inhibitors, about 30% reduction overall in terms of pain severity. Anticonvulsants, again, about 30% reduction in pain severity. We're not getting up even to placebo, which is between 40 and 50% reduction. And cannabis, controversial, and I'm not advocating here, but again, data supports as a drug, it may work. Again, the studies are complicated using different products, poorly controlled, and a whole host of different diseases rather than a single disease state. So recognizing the challenges even on the drug side, let's go to the right, the non-drug side. You can see that cognitive behavioral therapy and mindfulness up to 50% reduction. The last study I mentioned is true, 50% reduction with a combination. Exercise, 15%. Transcutaneous electronic nerve stimulation, 12%. Acupuncture, a big range of data based on the different approaches to study. Sleep restoration, above 40%. Hypnosis when added to CBT. Manual therapies, as you can see, up to 64%, but the very poor confidence in those qualitative numbers, again, because of the studies, yoga, Tai Chi, but I can certainly assert that there's never been an overdose of mindfulness, at least in my 35 years of practice. And I think we could add a little to the drinking water in most places and improve our pain treatments. So let's go through a summary of the major drugs that we would use in the multimodal drug analgesia side. Again, I want to just stress, starting with the non-drugs is critical. Often we don't even need any of these. But anti-inflammatories play a clear role in acute nociceptive pain, inflammatory conditions, trauma, in the perioperative space, to reduce the sensitivity of the nociceptor to that stimuli. Very simply, inflammation sensitizes the nociceptor to fire at a stimulus which is lower than prior to that inflammatory cascade. That's how the NSAIDs work. Antidepressants are effective for neuropathic pain, for that whole host of pain hypersensitivity syndromes we talked about, or the nociplastic state. They also help with sleep. if they're the more sedating type, typically the tricyclics, and mood. The anticonvulsant drugs or the antiepileptics, same term. Again, neuropathic pain, pain hypersensitivity, and sleep and mood. They look very much the same. They have similar effect size in a variety of studies managing those three states. It's your call as to which category you may want to start with. Opioids, we've talked about that a bit, but they do play a role for acute, moderate, or severe pain, and for some carefully selected chronic pain conditions, and only after other chronic pain treatments have failed before you venture into chronic opioid therapy. And local anesthetics will work very nicely for acute pain in a regional distribution of the nerve block, and it will provide transient relief for some chronic pain related to local nerve injury that might be associated with a disc impingement syndrome or the like. But they will last only the duration of the anesthetic effect, which with typical injectates is 4-6 hours. And we now have products that we can place actually in the wound, and that'll last 48 or 72 hours. But we're not talking about chronic relief with a local anesthetic. Now, this very busy slide, and I apologize, you'll have access to this subsequent, but this is adapted from Steve Stanos's very nice group article in Postgraduate Medicine. I've added to each category for the different treatments. So let's look on the nociceptive. Ice, heat, movement, TENS, sleep hygiene. I put asterisks next to the non-drug, and then you can see the anti-inflammatory drugs. Opioids, appropriate for nociceptive pain when it's at least moderately severe or worse than that, at the lowest dose for the shortest interval. And if there's an underlying condition, such as rheumatoid arthritis or Crohn's disease, i.e. inflammatory bowel disease, disease-modifying drugs to treat the underlying inflammation. The neuropathic in the top right, quite similar. You can see there's a few other choices. We have more evidence of CBT and BSR in that circumstance. Tricyclics, the gabapentinoids, several other categories of anticonvulsants. Opioids again, but for the shortest interval possible and only when severe. And then the predominantly sensory hypersensitivity syndrome, something that we commonly see in our primary care practices, sleep hygiene, exercise, TCAs, and gabapentinoids. There we go. No opioids, because we do know that opioids will worsen the outcome in management. So a quick word about NSAIDs reducing peripheral sensitization. As I mentioned, inflammation triggers a hypernociceptive milieu. It shifts the effect size to the left, just like when one acclimates to low oxygen, such as at altitude, that one will have a change in the hemoglobin oxygen dissociation curve. Similarly, for pathologic pain, you're shifting so that the strength of the sensory stimulus becomes much more perceived as pain, pathologic pain, compared to the physiological state. The challenges with NSAIDs are their side effects, gastrointestinal, renal, the non-selectives. In other words, the celecoxibs that are not selective for 2 have a coagulation effect. Typical advantage of celecoxib. It reduces GI a bit in terms of side effects, but it will not interfere with coagulation. Cardiovascular side effects for both, and the big debate about wound healing, not enough time certainly to go into great detail here as well. So how do antidepressants work? It's not just mood, although they will help mood. It's that descending inhibitory pathway. This has been well worked out. Some spinal functional MRI work is being done, and the clinical observation that a agent that increases synaptic norepinephrine is the magic sauce that lets these drugs work. Hence, SSRIs, not effective for pain. They're good for mood, for sure. They are easier to administer based on the higher safety factor for patients considering an overdose and the fewer side effects. But as pain goes, they will not reduce the intensity to the mechanisms of descending inhibition. And you can see to the left, the red line is the stimulus going up the ascending pathways and the descending pathways, cortex, hypothalamus, the periaqueductal gray, the medulla, particularly the dorsal ventral phase, very high norepinephrine transmitter concentrations in those areas will reduce the pain experience through these mechanisms. So it's an analgesic. Many of these will help sleep, and it helps mood. I call this the trifecta. In fact, when I joined the University of Washington about a decade ago, my nickname was Dr. Nortriptyline, which proved to be my first go-to agent in this category. So some key clinical points about antidepressant analgesia. Anything, again, that elevates synaptic norepinephrine, tricyclics more so than the SNRIs. We do dose increase the SNRIs to get up to enough norepinephrine, so generally you have to increase the dose above the standard antidepressant levels. Sedating antidepressants may help sleep and sleep maintenance, and the quality of sleep is maintained in terms of onset of REM and REM duration. Anticholinergic side effects are a problem: dry mouth, constipation, prostatic, strangling urinary outflow. Nausea is common with the SNRIs. QT prolongation is a significant issue at higher doses, and if individuals are on QT prolonging drugs already, i.e. most drugs that are associated with management of arrhythmias. And one needs to warn the family and patient about suicidality whenever an antidepressant is prescribed, and occasionally and rarely mania or manic depressive disorders may be precipitated by any category. The gabapentinoids, the family name is named after gabapentin, which has nothing to do with the GABA receptor. That was the early thought. It was modeled after that, but it seems to work by selectively inhibiting voltage-gated calcium channels. A particular subunit is involved. We know in functional imaging of the brain that the insula is involved, particularly the posterior surface of the insula can be suppressed in its activation of the glutamate excitatory signaling. We're still working out how these work. They are easier to prescribe than the sodium channel anticonvulsants. They're 100% excreted in the urine. So if the patient's anuric, you need less, but one has to worry quite a bit less than about the interaction with other drugs that are metabolized to the liver. Weight gain, edema, cognitive slowing, dizziness, and ataxia are quite common. Notice we don't have to worry about sodium levels. We don't have to worry about blood counts as we might with the earlier sodium channel agents, such as carbamazepine or oxcarbazepine and valproic acid that can have these other problems. So they are easier to administer to our patients in terms of less monitoring. Suicidality is rare, but has been reported. And there's one fairly recent report that I've referenced here for you, that at a very, very high dose, there has been a few overdoses identified, but they appeared not to be nearly as dangerous at high dose, and one just needs to be attentive to dosing. Benzodiazepines, I've mentioned, lack of evidence for sustained benefit, rebound insomnia, risk of oversedation, complicates development of tolerance, dependence, and addiction, and that there's not a single guideline at this point that says anything but high caution when combining benzos with opioids in chronic pain in particular. But in terms of benefit on sleep and benefit on anxiety, we do have evidence-based treatments that are proven effective, and benzodiazepines are not recommended long-term treatments for sleep disorder or for generalized anxiety disorder. So a big red X through considering benzodiazepines. Anti-spasm drugs, limited effectiveness for chronic use. They're far less lethal than many of the other mildly sedating drugs we give our patients, with the exception of carisoprodol, which is metabolized to meprobamate, which was withdrawn from the US market based on its lack of proven benefit and its high rate of development of tolerance dependence and a withdrawal of carisoprodol will generate a delirium tremens like response in our patients. So there's clearly no indication. There are circumstances, stiff person syndrome. I'm sure you will have a dozen or more in your practice. I'm being facetious, of course, but in that circumstance, benzodiazepines do play a role, or in spinal cord injuries, perhaps, but more importantly, baclofen or tizanidine, which are anti-spasticity drugs. Be cautious about abrupt withdrawal of baclofen because of rhabdomyolysis and fever. It's actually a life-threatening condition. So a few words on the fact that it's not just about us prescribers. Of course, the medical leadership of the team is important, but nursing, pharmacy, physical therapy, occupational therapy, behavioral health support at all levels, PhD, licensed social workers, nurses trained in specific techniques in terms of reducing pain expectancy and managing pain flares. Focus on behavioral health is critically important. Chaplain and spiritual, not just for the pale of end of life, but for people who have found no meaning and purpose, and therefore nothing else matters. And therefore opiates and benzos become the preferred treatment in this group unless we attend to the need to find purpose in one's life. And of course, an addiction specialist when things go wrong. American Pain Society has put together a very nice piece that describes the components of interdisciplinary team management. Valuable knowledge and complementary skills are shared, it's collaborative, and decisions are consensus-based. So putting this all together in terms of the biopsychosocial and focusing on the multidisciplinary interprofessional side, how much evidence is it that they work? Well, I just listed a smattering of articles on a search through PubMed here in the US that I looked at just behavioral management and CBT and using a more formal multidisciplinary chronic pain program, which incorporates the individuals and the team in a simultaneous way or near simultaneous rather than in a series where we'll do the physical therapist and then we'll do the behavioralist and then we'll do the occupational therapist, but putting them all together simultaneously makes it a more of a multidisciplinary approach. But nonetheless, you can see in the bottom right, dramatic reduction in direct costs, 40% reduction in disability costs, and yet these programs are becoming few and far between. So nearing the 10 minutes of questions, I hope we'll have them. We can have a nice discussion. Let me wrap up a little bit. Now, Voltaire attributed, actually, no one knows if he actually said it, it's not published in any work, but nonetheless, it's a great line, and I think it still applies to what we see today. Doctors pour drugs, of which they know little. We know a bit more than back in Voltaire day, but we're still not sure, as I've mentioned already, even how the gabapentinoids truly work. For diseases of which they know less, we've done a nice job of understanding diseases, but into patients of which they know nothing at all. And the sad fact of the matter is, in our hurry to get through our complicated day, managing complicated patients with multiple chronic diseases, it's difficult to find the time to learn about all those domains, but at least we can collect the data, as I've alluded to, and begin to crack this code. Francis Peabody published New England Journal back in 1927. As a surgeon, he was speaking to medical students, and he said, I think the most important line of all, the secret of the care for the patient is in caring for the patient. And that requires us to maintain empathic and a respectful shared decision-making relationship with our patient and their family in order to make progress, and especially in hypersensitized patients who have not just pain hypersensitivity syndromes, but sensitivity to the odd glance at your watch or the rushed visit or the can't get out of the room quick enough type attitude that we often show our patients. And finally, one of my colleagues, Dr. John Lozier, many of you may know him, one of the disciples of John Bonica, the founder of modern pain medicine, reminds us time and time again that chronic pain is not a state of opioid deficiency. So I think we do have time now. I think I'll leave that image on as we move forward, but can bring back other images as we move through the conversation. So, time for questions.
Thank you. To our audience, if you have any questions at this time, please enter them to the question box on the GoToWebinar panel, and we'll answer them out loud. One question that came in, at your organization, what is the general process for determining severity of pain? For instance, do you ask the PTSD screener to all patients?
That's a great question. So I think in the setting of acute pain, and whomever asked that was really spot on. I'm going to get out of the slide set here, if I can, and go back to those tools so we can look at those in a moment. Where was back? I can't remember where we organized. Here it is. All right, open up to this slide here. So in acute pain, I think it's not important at the get-go if a person's broken their ankle or is acute traumatic injury or is post-op to do a deep dive necessarily after the fact. If you have a system of preoperative screening, which we have introduced in our system at our trauma hospital, we do pain catastrophizing in advance. We do the full risk screening profile that you see here. But in the ordinary circumstance, asking pain intensity is useful, and being attentive to those individuals who do not seem to be responding properly. I think before you refer a patient for hip or knee surgery, I think it makes sense to do a fibromyalgia screen. Again, it takes under a minute to be able to identify with the patient in advance that they have a high risk of having pain in that joint even after it's mechanically fixed, and will reduce the likelihood of chasing after ghosts and demons in that joint after the orthopedist assures us that indeed there's a wonderful orthodesis there and nothing more needs to be done. So I would say in acute settings, it's important to think of these things, and at about 4 to 6 weeks out after you would have considered acute injury, if the pain persists. So the data we know is at 90 days or 3 months out, or 12 weeks, pain often becomes chronified, which means that the central nervous system is playing a larger role, and that nociplastic events, hypersensitivity syndromes, begin to grow, and we need then to take a look before we get into the 90-day domain. So I recommend, and our institution tries to put this as a standard approach, though there is some variability, but we strive for this. At 6 weeks out, if the patient's not improving and you'd expect them to be improving at a faster rate, then I would recommend the PEG-3, the PHQ-4, and as the slide says, if it's elevated, and elevated means if you get 3 points for every number, so the PHQ-4 is 4 questions, 3 points for the worst, that's 12. If you're halfway up or more, it's elevated. So a score of 6 on a PHQ-4, we then trigger to the full PHQ-9, the full GAD-7, and the PTSD screener. If you know a lot about your patient in advance, you know they've had a rough go in early life, and they've been pain sensitive for a whole host of other conditions, as we saw in the UNIS pinwheel of other common primary care medical circumstances, I would introduce this far earlier. Querying about sleep, I wouldn't wait full 6 weeks. I'd talk about it early with the patient, and after a few weeks of follow-up, they're not sleeping well, begin to think of some strategies, such as icing, such as quieting the mind, such as deep breathing and relaxation. Gabapentinoids are actually good sleep drugs if used at HS, and they can be given just at bedtime, and the tricyclics. Many of prescribers in the United States will use a brand name Flexeril or cyclobenzaprine. That's a tricyclic antidepressant drug. That's not been studied in depression. That could be used at HS, 5 or 10 milligrams, even 20 milligrams at HS. Again, a non-opioid strategy if the sleep hygiene doesn't work. And paying attention early on to whether if opiates are being used, our prescription monitoring programs, our urine drug testing, which is part of the Canadian 2017 recommendations. And in advance or as you're moving, sleep apnea, certainly if opioids and certainly if benzos are being used, because these will not only interfere with sleep, but increase the risk of adverse outcomes. So a great question and a long answer, but it allowed me to review some of the key concepts. So thank you very much.
Mm-hmm. Another question that came in the slide concerning interdisciplinary approach, is there a role of nutrition and supplements?
You know what? I am remiss for not actually mentioning nutrition. So magnesium, excellent, bit of a muscle relaxant. It's thought to reduce some myofascial pain syndromes, and it's a great laxative if your patient's constipated from treatments or otherwise. You can see I'm hustling down to find that list here. I'll bring that slide back up again. It is my omission. We know that there's lots of talk about high inflammatory diets. There's now pretty clear evidence that glucose intolerance leads to a clear inflammatory state. So if we make the jump into high inflammatory diets, which are basically foods that are white, flour, sugar, for instance, those foods likely do increase, even in lean patients, a mild state of hyperglycemic condition, and that may produce inflammation. The data is not good as we'd like it to be, but it's at least as good as the opioids we're prescribing. And one other obvious thought is chronic back pain, knee pain, hip pain, ankle pain in a patient whose BMI is elevated, even moderate obesity or certainly morbid obesity. You're not going to solve that without making an effort to change the environment of that body, which is being compressed by dozens of extra pounds of weight. So I will make a slide change. Thank you. Appreciate the question. It will lead to an action.
Mm-hmm. And I think we have time for one more question, but we did have a lot of questions, so I will send those to you through email. One last question. Can you cover a few points on improving sleep hygiene?
Yes, I would suggest you just pop onto whatever your search engine is and look up sleep hygiene. There's a lot of literature on that and a lot of self-management advice. Simple things is regular sleep time. Weekends, you don't stay up real late and sleep in late. Every day you have the same circadian clock set into your system. Alcohol makes people feel groggy, but after an hour or so, it activates and disrupts sleep quality. So avoidance of alcohol. Certainly caffeine, maybe entirely, but after 12 noon in patients. Exercise, light is fine, moderate is better. Early in the day, again, not right before you might be inclined to retire for sleep. Anything with a blue screen tells our pineal and other structures in our brain that it is daytime and we need to stay awake, and will disrupt our circadian rhythm. So reading from a blue screen, so maybe it's time to put those electronic reading devices down, unfortunately, and pick up a paper book that doesn't shine light right back into your brain, but TV, computer screens, and the others. And there is an option now, I understand, taught to me by one of the younger trainees, that you can get the low blue light screen option if you're going to be looking at those sorts of screens. And then deep breathing, relaxation training, and the like. But regular circadian rhythm, avoiding blue screens, avoiding alcohol, caffeine, and finding yourself in a restful state. And of course, when you're in bed, it's to sleep. It's not to do other work, other than intimate work perhaps, but not to do other work, because that conditions the body into being in a wake state in that particular environment. Okay. So unfortunately, I understand there's a lot more questions. I'd love to take a crack at some of the others, because the ones that I've been asked are excellent. I'm sure they're going to be just as good. So I apologize for talking too long.
Absolutely. We'll take those offline. Do you have anything to add following the presentation? There's a lot of good information here. Dr. Todd?
I just want to thank the audience, and if you don't get a sense from me that I really believe in what I'm doing, because I've seen it work, then I've not been successful because this is not stuff that any individual who takes care of chronic disease would be unfamiliar with in terms of this. The deep understanding of our patients goes beyond just the presenting biomedical condition.
Absolutely, and thank you so much for your presentation.